All right, hey there, future nurses. Welcome to this OB QuickClip. Think of this as a rapid-fire review of the absolute foundational knowledge you need. We're going to cover the incredible ways the body adapts to pregnancy, the key assessments you'll be doing, and the essential nutrition that makes it all happen. So, let's get right into it.
Okay, let's jump right into a situation you're going to face constantly. A patient walks in, they think they might be pregnant. So, what's your first move? How do you help them go from, "I think so," to a definite yes? Well, it all starts with understanding exactly how we classify the signs of pregnancy.
So, here's our game plan. First, we'll nail down how to confirm a pregnancy. Then, we'll explore the amazing system-by-system changes happening inside the body. After that, it's all about your key assessments, what to teach about nutrition, and finally, pulling it all together into a solid plan of care.
First up, let's talk about actually confirming it. You know, it's not as simple as just looking at a home pregnancy test. As a nurse, you're basically a detective. You're gathering clues, and we sort those clues into 3 different buckets to get the full clinical picture. Okay, this is a huge clinical point, so listen up. That positive pregnancy test your patient took, it's only a probable sign, not positive. Why? Well, because some really rare conditions can actually trigger a positive test too. The first category, presumptive signs, is what the patient feels and tells you about, like fatigue or a missed period. The only things that are 100% proof positive, the real deal, are the things we can directly see, hear, or feel. We're talking about hearing those fetal heart sounds, seeing the fetus on an ultrasound, or an examiner actually feeling it move. Can't argue with that, right?
So what is that pregnancy test actually picking up? It's a hormone called HCG. It starts getting produced right after implantation. And for us, as clinicians, HCG is way more than just a simple yes or no. The level of HCG tells a story. Super high levels? Maybe we're looking at twins. Low or falling levels? That could be a red flag, an early sign we need to watch for a potential miscarriage.
So pregnancy is confirmed. Now the body starts this absolutely mind-blowing transformation. It's truly incredible. Let's do a quick head-to-toe tour, system by system, to see what's really going on under the hood. Naturally, the reproductive system is ground zero. We keep tabs on the uterus's dramatic growth by measuring what's called the fundal height. And here's a landmark you've got to remember. At 20 weeks, the top of the fundus should be right at the belly button. By 36 weeks, it's all the way up to the xiphoid process, which is exactly why so many patients feel short of breath. There's just no room. You'll also see things like Goodell's sign, that's the cervix softening, and Chadwick's sign, a bluish color from all that extra blood flow.
The cardiovascular system basically goes into overdrive. Blood volume and cardiac output surge to supply the placenta. The heart rate climbs, and the heart muscle even gets a little bigger to handle the extra workload. Now, all this creates something really important, a hypercoagulable state. This means the blood clots more easily, which is protective against hemorrhage at birth. But it's a trade-off, because it also increases the risk for a deep vein thrombosis, or DVT.
And this leads to an absolutely critical piece of patient teaching. When a pregnant patient lies flat on their back, that heavy uterus can literally press on the vena cava, causing their blood pressure to drop and making them feel dizzy. We call it supine hypotensive syndrome. And the fix is so simple. Have them lie on their left side. This is one of the most important and effective things you can teach.
Okay, the respiratory system. The body needs about 20% more oxygen, but at the same time, that growing uterus is pushing up on the diaphragm, causing that classic shortness of breath. In the GI tract, the main character is the hormone progesterone. It relaxes smooth muscle, which slows digestion way down. And the result? You guessed it, heartburn, constipation, and even a higher risk for gallstones.
All that extra blood flow to the kidneys causes that well-known urinary frequency. But that same smooth muscle relaxation can lead to urinary stasis, putting patients at a higher risk for UTIs, definitely something to watch for. On the skin, hormones can cause hyperpigmentation, leading to chloasma, the mask of pregnancy, and the linea nigra, that dark line down the abdomen.
All right, so we've seen how the body is completely transforming. Now let's pivot and talk about your role in all this. That first prenatal visit is huge. It's where you lay the groundwork for the entire pregnancy, and it all boils down to your assessment.
One of the first things you'll do is get an obstetric history using the GTPAL system. It gives us a much richer picture than a simple gravida/pair account. G is for gravida, total pregnancies. T is for term births, P for preterm, A for abortions or miscarriages, and L for living children. It's like a complete obstetric story in 5 digits.
Let's make this real. Your client is 25 weeks pregnant. She has 5 living children and had 1 miscarriage. So how many total pregnancies? Well, this one, plus the 5 births, plus the miscarriage, that's 7 pregnancies. G is 7. 4 children were term, so T is 4. 1 was preterm, so P is 1. She had 1 miscarriage, so A is 1. And she has 5 living kids, so L is 5. Her GT-PAL is 74115. See, it tells the whole story.
Next, you'll calculate the estimated due date using Nagel's rule. It's a super simple formula. You just take the first day of the last menstrual period, subtract 3 months, and then add 7 days. Boom! That's your estimated due date. Easy as that.
A critical lab test is for the Rh factor. Now, this is a big deal. If a patient is Rh negative and their fetus is Rh positive, her body can create antibodies that could harm future Rh positive pregnancies. To prevent this, we administer Rogum, a medication that literally stops her body from making those antibodies. It's usually given around 28 weeks, and since it's a blood product, it always requires a 2RN check.
Now for one of your most powerful tools, patient education about nutrition. We need to talk about fueling for 2, because what a patient eats directly impacts fetal development in a huge way.
Let's focus on the nutritional power players. Folic acid is non-negotiable for preventing neural tube defects. Iron is vital for all that expanding blood volume. And here's a clinical tip. Teach patients to take it with vitamin C, like a glass of orange juice, to boost absorption. Calcium builds the fetal skeleton and is best absorbed with vitamin D. And of course, protein and fluids are the basic building blocks for everything.
The big question, how much weight should a patient gain? It's not a one-size-fits-all answer. It's based on their pre-pregnancy body mass index, or BMI. Someone with a normal BMI is advised to gain about 25 to 35 pounds, while someone who is underweight should gain more, and someone who is overweight is advised to gain a bit less. So what does that look like week to week? For a patient starting with a normal BMI, the target during the 2nd and 3rd trimesters is a steady gain of about 1 pound per week. It's a simple, powerful guideline you can use to help patients track their progress.
Okay, let's bring this all together in the plan of care. Your most important role, honestly, is often as an educator, empowering your patient with the knowledge they need to navigate their pregnancy safely.
You're going to spend a lot of time providing guidance for these common discomforts. The advice is often simple but incredibly effective. For nausea, small, frequent meals are key. For constipation, it's all about fiber and fluids. And for backaches, teaching proper body mechanics can make a world of difference.
And finally, the most critical education you will provide. These are the red flags. You must ensure your patient knows to report any of these signs immediately. Vaginal bleeding, a severe headache that won't go away, visual changes like blurred vision, or sudden puffiness in the face, these can all be signs of serious complications like preeclampsia. This knowledge is potentially life-saving.
You know, pregnancy is a journey. And while it's a normal process, it's filled with profound changes and potential risks. As a nurse, you are the navigator, the educator, and the advocate. So the question to leave you with is this: how will you use this knowledge to become the trusted guide your patients need to navigate one of the most important times of their lives?